The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss Patient Advocacy, Pearls for Living One's Best Life. My name is Emily Lippert, Program Manager here at the American Brain Tumor Association. I am delighted to introduce our speaker today, Dr. Erin Dunbar. Dr. Erin Dunbar specializes in the comprehensive care of brain and spine tumor patients with primary and metastatic tumors. A certified provider of MD Anderson Cancer Network, she serves as the Director of Neuro-Oncology and is a founding physician of the Piedmont Brain Tumor Center. Providing a robust portfolio of promising clinical trials and novel therapies to serve the needs of her patients across their lifetime is Dr. Dunbar's passion. She serves as the Community Oncology Alliance Patient Advocacy Co-Chair and is an active member of the following academic societies, where she is involved in the care of primary and metastatic brain and spinal tumors, including the Society of Neuro-Oncology, American Society of Clinical Oncology, the American Academy of Neurology, and the Georgia Society of Clinical Oncology. Dr. Dunbar is committed to providing the highest level of compassionate care to patients, caregivers, and referring physicians. Thank you for joining us, Dr. Dunbar. You may now begin your presentation.
Thank you all for the opportunity to speak today. It's a true privilege. There is nothing that I need to disclose other than educational advisories that I do for Celldex and Novacure. So a little bit about me: I do neuro-oncology, medical oncology, and hospice and palliative care based out of Atlanta, Georgia, Piedmont Brain Tumor Center. And one of my passions is being able to care for people anywhere along their healthcare journey. And I really do consider the privilege of being someone's care home. And I hope that each of you find a care team that you trust to assist you or your loved ones along your lifetime journey. So we're going to start the educational series. Today it's going to be about patient advocacy, pearls for living one's best life. There's 3 distinct subsets that I really felt strongly about sharing with each of you. The first are what are the behind-the-scenes medical pearls that each one of us specialists really want to make sure that our patients and their caregivers know. The second is talking about strategies to optimize your interaction or your loved one's interaction with any part of the healthcare team. Thirdly, we wanted to talk about advocacy and empowerment tips and how to optimize the lives of everyone touched by brain tumors. So to begin the first part, medical pearls of wisdom that all of your specialists want you and your loved ones to know. Firstly, there's been an explosion of advancements that we're going to talk about. And I wanted to get each of these to you to make sure that you are talking with your healthcare team to see if any of these are right for you. The picture on the top right is reminiscent of the concept of early medicine when we were first approaching any type of tumor, whether it be a benign or malignant tumor. It was reminiscent of whack-a-mole. We were either going to crudely cut it out, crudely do radiation, crudely give chemicals, and really hope that that got the job done. Now we've gone into a much more evidence-based model where we have individual clinical algorithms for each individual patient. We utilize not only best evidence, but also incorporate patients' goals, wishes, values, and the individual's information that their body is trying to tell us. So we think of this then as a hybrid of what can we do to lower the burden of the tumor or tumor-directed treatment, whether that's lowering the volume or speed of tumor or lengthening the life as we are best able. But equally important is what can we do to lower the symptoms of the tumor. So that may need memory, cognition, fatigue, quality of life, someone's functional independence. And really what this translates to is a balance between the risks and symptoms of the tumor versus the risks and symptoms of the treatment, and how can we stack the odds in the patient's favor that they live their best and longest life. There's been advances in how we understand the imaging of the brain and how we monitor tumors and monitor treatment effects. So we have had an advancement in understanding physiology and how that is greatly impacted by what we like to call a broken blood-brain barrier. So naturally, as we're made, we have a watertight seal between the blood circulation in our body and that of our brain. And that's helpful every time we get a rusty nail in our finger or a cough or a cold. That doesn't translate to an infection that's going to go to our brain. However, that means that if we put IV dye from a contrasted CAT scan or MRI, that dye doesn't necessarily get beyond the body's blood vessels into the brain and illuminate the brain. However, in many disease processes, there is an abnormal blood-brain barrier or a broken blood-brain barrier that may represent the disrupted physiology of that state. So prior to knowing someone has a tumor, that same abnormal blood-brain barrier with leaky dye in the brain may be instead an infection, a trauma, a stroke, etc. However, once we know that that's a tumor, it tells us globally where there is tumor that is created in enough population to be able to see a mass, or also where tumor has created enough inflammation and broken the architecture of the brain to cause a leaky blood-brain barrier. Furthermore, once we institute treatment, we may have additional reasons why the brain is taking up more dye because we might have caused some inflammation or injury from the treatments themselves. So that's a very important point that hopefully you can talk with your healthcare providers more about to see how does that affect the monitoring of your or your loved one's tumor. A few examples to describe that. We have many different types of tumors that when we treat them, we actually make the scan look worse before we make them look better. And so the pictures that are just up on the screen are actually coronal images, just the orientation of the MRI of someone in the first part of the picture. The first brain is postoperative, and the lower picture is after they've endured radiation and chemotherapy. That scan at the bottom looks for all the world like to be tumor progression to any one of us at first glance, but in reality, that's actually the inflammation and cell kill that we tried to create. So instead of thinking that's tumor progression, we treat patients with supportive care and lots of symptom support, maybe steroids, maybe other things, and then the overwhelming majority of the time, that inflammation process calms down over a period of weeks, and then the scan goes back to looking like the one above it, which was back to, it's very similar to baseline state. We call that increase of inflammation and dye leaking in the brain pseudo-progression, because it's not reminiscent of true biologic tumor growth. It's more reminiscent of that leaky blood-brain barrier becoming more leaky, like the picture I showed before. Now I'm going to flip the scenario to the other continuum and say that there are also things we can do in terms of treatment and medicine that can make this scan look better, even though we've not created a biologic tumor kill. So for instance, the use of steroids or certain types of anti-angiogenic or anti-blood vessel therapies actually can make the scan look better, even when we don't biologically think we've killed tumor that rapidly. In many different, in other words, it's almost like hiding the tumor. So these are very important concepts to talk to your healthcare provider about what is the best modality to image your loved one or your brain tumor. There's also been advances in how we think about personalized treatment over one's lifetime. In my personal analogy, which I encourage you to consider, I think about engaging in a relationship with a patient, much similar to us beginning to write a novel together. And so if I lined up a patient of mine and 3 other patients that looked similar to them with respect to the way the brain scan looked, etc., they may have a different experience with respect to their treatment chapters. So I think of periods of treatments or periods of surveillance as being chapters in a novel we're writing together. So each person will have a different experience at each one of those. So some of the things that I can do to advocate for my patients and your healthcare providers can are to, by that same analogy, add as many pages to each chapter, help squeeze out as much benefit out of every therapy. Secondly, we can be smart and efficient about changing chapters. And we're going to talk in the future about how that might be done with tumor boards or multidisciplinary clinics, etc. And thirdly, we always want to maintain many good options for our patients. And that might be routine therapies, it might be clinical trials, etc. But the binder of this novel, our patient's quality of life, as I will often discuss with my colleagues, it doesn't matter if we have very novel, exciting vaccine trials or other new surgical tools. If patients aren't well enough to be able to get the therapies, or they're not desiring to get the therapies because of how they feel. So the binder of everyone's journey in their novel is their quality of life. We've had advances in pathology analysis or tumor tissue analysis. In the top right, this is reminiscent of how we used to be able to characterize people's tumor. How much tumor looked alive, how much tumor looked necrotic or dead, what was the basic cell type and personality of the tumor. However, increasingly, we are relying on molecular and genetic abnormalities well below the level of the microscope. We are now looking at RNA and DNA mutations in the tumor, or other types of cellular metabolic perturbations in the tumor, or even in the patient's local brain tissue that tell us much more about how we can best fight that individual patient's tumor. So now if we think of a tumor type like glioblastoma, that is a type of tumor that is extraordinarily heterogeneous under the level of the cell. If I took 100 patients with a glioblastoma, then I have a completely different molecular genetic profile. And each of those understandings makes us smarter at how to help the patient. Those molecular and genetic abnormalities are increasingly being used to be able to get an FDA-approved drug. For instance, in metastatic melanoma that affects the brain as a brain metastasis, if you're going to use one class of drugs, which are called BRAF inhibitors, you have to have the BRAF receptor mutation or you cannot get that drug approved. Furthermore, these molecular and genetic aberrations help us select treatments for each individual patient, potentially help us select a trial, or help in what's called prognosis and prediction. So the picture down in the bottom right is an example of those two factors. And a good analogy of prognosis and prediction is very similar to nature versus nurture. So a prognostic factor is something that's innate or inborn in that cell or in that individual, and that even if there's external events, it kind of doesn't change the outcome because it's already fated or innate. And that's very similar to nature. On the other hand, you have the concept of nurture, which is more analogous to prediction. And that means that there's some outside external event that can fate or turn the outcome in that individual or that tumor cell. And that would be more analogous to nurture concept. So you can have examples of prognosis that can affect outcome and things that are predictive. We can apply an external event and change the outcome and be able to predict it. The last comment I want to make about advocating for brain tumor patients is that each one of us are the guardian of our own tissue or that of our loved one. And we have to make sure that our providers are as well. So that means prompt and thorough analysis of our tissue. Are the right things being done with our tissue that are going to give each of our patients the best information to make a real-time treatment decision? Also, only use what's necessary. Don't run every test we can possibly think of. Do tests that are actually applicable to real-time management, or they're going to help with the factors we just talked about, like prognosis or prediction. But then save the rest for potential future use. We have patients all the time that have brain tumor tissue that there was no immediate need for it, but down the line, later on in their life, a new marker came up or a new drug came up, and we were able to use their older tissue where it was originally archived, staying in that hospital's pathology department, to be able to retrospectively test it and figure out that a particular trial or treatment or drug is right for them. And then wherever you get your tissue analyzed, consider doing it in a place that also contributes that data to a larger research goal. For instance, there are some private labs that mostly just punch out the test almost as a money-making program, or there's other places you can get your tissue tested that also donate all that knowledge to research, such as maybe an academic center or other pharma and industry analyses that are basically committed to contributing to research. I want to talk a little bit about some advances in surgical treatment. There have been some phenomenal advancements, including intraoperative frozen sections that help make sure we get the right negative margins or help tell us what type of tumor it is early so that we can decide if we need to collect the tissue subsequently during the surgical experience such that we can make a tumor vaccine from their tumor tissue or be able to get them into a surgical clinical trial where maybe we put in wafers or treatments into the brain. So knowing what it is as early as possible helps make sure that we're not doing surgery when we don't need to and that we're maximizing all the value of the surgery, either getting the most out or being able to then actually do a surgical type treatment when we're in the middle of the surgical experience. We can enhance the amount of resection by using things like neuronavigation, which are some of the pictures you see there, where we can create a 3D model of your CAT scans and your MRIs and your PET scans. And while the patient and their brain is moving through blood vessel flow and breathing, and the surgeon is actually being able to touch the brain tissue, then you can actually be able to approximate that with the imaging. The picture that you see on the left with the blue turquoise ball and then the two colored lines, that's an example of using functional imaging to see where a tumor is with respect in 3D space to delicate motor sensory tracts. And an important point to know ahead of surgery is a tumor invading delicate structures, or is it adjacent to delicate structures, or is it just pushing on delicate structures? Because that makes a tremendous difference in terms of the goals of surgery, how much we think we can cut out, but also it makes a difference in terms of preoperative consenting. And should it be done awake or should it be done asleep? Or what are our expected outcomes? Some of the pictures on the right are just different types of tools and equipment that may be available to your surgeon. Very importantly, not all the tools need to be used on every patient. You might have heard, well, someone needs intraoperative CT or MRI, or somebody needs awake surgery, or someone needs this, or someone needs that type of monitoring. Talk to your neurosurgeon and maybe get a second or third opinion and figure out what are the tools that are needed for my type of tumor. But not everyone needs each one of these. There's also been tremendous advances in imaging. And again, talk to your healthcare team to see, do these images help make real-time treatment decisions for me? Sometimes they don't at all. Sometimes they might be fraught with false positives or false negatives. So let me explain a few of the goals. The pictures on the left represent typical MRIs that you see in black and white. And I've developed those pictures looking at a surgical cavity as well as what you see below that surgical cavity as some image abnormality. Well, the question comes up, is that tumor growth, or is that radiation treatment effect or necrosis? Is that an inflammatory reaction? Is that an infection? So it's quite important what that is. The colored picture on the bottom right of that four-pictured screen really shows a cold or an absence of imaging. And the example to that is that you can have dye leak in the brain or fluid or tissue characteristics be worrisome looking on certain images. And then if you develop the picture using the right computer programming and the right sequences, you can get additional images that may clarify what the other ones were trying to describe. So that colored picture at the bottom really just describes that even though you see red and yellow and green normal brain blood vessels, there is a paucity or an absence of brain blood vessels where we're worried there might be tumor. So that shows that instead of that being an alive biologic area, that area is not alive and more reminiscent of necrotic scar. Some of the pictures on the right, the gray and white one that's listed A, is an example of structural imaging we can do. B is an example of connectivity or white matter tracks. So if we want to see if there is a delicate structure we're going to traverse with a knife or a scalpel or radiation, that can be quite helpful. The picture on the bottom left, the functional MRI, C, and then D, the PET, are examples of being able to evoke function. Is the area of the tumor near the area of my speech, or the motion of my hand and leg, or the sensation of my hand and leg, or my area that would help me walk or empty my bladder? And the picture on the right often tells us how hot or cold metabolically is a certain abnormality. Is this area alive, or is it dead? And is it growing tumor or burnt out tumor that's already treated? So extremely important concept. Once again, not all of these imaging modalities are needed for every patient every time. So you want to be able to talk to your healthcare provider if these are right for you. There's also been tremendous advancement in radiation. And you see at the top one of the examples of some of the less claustrophobic machines that can move around each patient in real time. The pictures along the right-hand column show different dosing strategies and how we can paint radiation to go where we want and not where we don't. So very similar to that color Doppler map you might see of a storm radar screen. We can paint the amount of radiation where we want it. We can even bend it around structures that we don't. And radiation could not be more different. There's fractionated radiation that's done in many different smaller doses, or there's one-time radiation that can be done in different strategies like stereotactic radiosurgery, often called LINAC, Gamma Knife, or CyberKnife. Each one of those are specific to the goals of each patient and each tumor, and these are worthy of discussion with your clinician. And then the picture on the bottom left is just an example of photon versus proton radiation, and I know each one of you guys have heard about the two different modalities. There are two different energy waves that do different things, and neither are better or less or inferior. It's just about matching the treatment to your tumor and your needs. I'm going to talk a little bit about advances in medical therapy. These pictures are just cartoons to describe that there's been an explosion of treatments that need to be individualized to each person's tumor and treatment. They get called terms like small molecular inhibitors that may affect a particular receptor on the outside of the tumor cell, or a marker inside the tumor cell, or the tumor cell's DNA as opposed to the rest of the person's DNA. They may be immunotherapy, where we're either implanting antibodies in patients to fight tumor, which would be sort of adoptive immunotherapy, so to speak, or we can give other types of immune therapy that are stimulating your own immune system to fight the tumor. And that might be using a sample of your own brain tumor, or it might be using a proprietary set of chemicals that mimic the unique features of a brain tumor to be able to stimulate your own immune system to fight the tumor. And then on the top right, we have examples of anti-angiogenic therapy, where we are often trying to not let the tumor grow its own blood vessels, or be able to lock into your brain tumor blood vessels, or lastly, to be able to normalize the blood vessels so that they have less extracellular leakage of swelling and edema. But also, if the blood vessels are more normal, it allows the chemotherapy or other things we get to get to the tumor tissue without it leaking out before. And then lastly, we have an explosion of nanoparticles in which we've been able to make radiation and chemotherapy and other types of treatments like immune therapy so unbelievably small that not only can we get them to the target tissues better, but we can often use a fraction of the dose and it be tremendously better tolerated. So each one of these are advances that we're making in medical therapy. And some of the pearls in this situation is understanding the goals, the safety, and the tolerance of each of these medicines. If you're on any of these medicines or radiations or surgical strategies, talk to your healthcare team about symptoms promptly. That might even include taking photos or diaries. And remember that, especially as we're dealing with advanced, new, emerging treatments, your providers are learning about these treatments in real time just as you. So you actually can partner with your healthcare clinician to really make sure that each of you are learning these technologies as quickly as possible. And this is just a cartoon to describe that now we have just an explosion of new ways to give local drug therapy, local radiation therapy, and even in real time detect what the tumor is trying to tell us. Is it sending out cytokines and interleukins that it's dying? Is it creating more chemical that we can measure? There's able now to be microchips and catheters that can tell us things in the tumor bed, or to dispense chemicals or chemotherapy into the tumor bed. So each one of these are emerging technologies that may be part of a clinical trial for you or your loved one in the future. If you have any questions about it, how these may or may not apply to you, go to well-vetted websites like the ABTA and talk to your clinician. And lastly, there's been advances in treatment modalities. We just talked about surgery, radiation, and medicine, but now there's a fourth modality. Now as we think of each cell is subject to gravity, and each cell in our body has a positive and negative charge. And that positive and negative charge helps each of our cells do good, normal things like get chemicals up to the cell surface to be able to be utilized by the body, or make sure that the chromosomes line up for division and mitosis. Well, tumor cells have a polarity as well. And so what we've been able to figure out is by giving unbelievably low doses of energy, we can actually ever so slightly perturb the energy of the cell that is a tumor cell to get it to act less like a tumor cell, and in many times not be able to grow and to divide and to ultimately go into a death signal and die. We're able to apply that low dose that low dose energy through a non-invasive way by putting very, very, very small non-warming ceramic plates using what is very similar to like a Band-Aid kind of wrapper, be able to put those on the outside of one's shaven head and be able to apply an external, wearable, portable, removable treatment that then can be targeted specifically to one's tumor through the use of very sophisticated computer planning. This can be started in the comfort of your own home. You can have a certified clinician be able to modify and optimize your treatment plan. This is becoming available to glioblastoma patients, those that are newly diagnosed and those that have progressed, as well as increasingly to other tumor types like meningiomas, brain metastases, etc. So you can find through the website where a certified provider may be and find out if a treatment like this is right for you or your loved one. I'm not going to tell you that there's also been advancements in how we approach helping patients come up with an individual treatment that's right for them. So I affectionately call them starting and stopping rules. So how do we know what and when to start a new treatment? We talked about a new treatment chapter. Well, your clinicians are going to do everything they can to narrow a treatment down to what's most likely to be equally safe in how it helps the patient feel as well as the science. So let's say that we narrow down as 5 or 6 good options that are equally safe and equally likely to work. Well, then there's a heck of a lot of other things we need to figure out. Your goals, your wishes, the strategy, such as the order of therapy. Would one treatment now likely exclude you from another treatment later, etc.? Logistics, is it a pill or an IV? Is it inpatient or outpatient? How often would you have to do it? What would the cost be to you? Is there a trial you could be a part of? What would be the support needed by other people in your life? Where is it located? How can you get it? Once you go on treatment, there are many tools to help see how you're doing in that treatment chapter. Your physical exams, your health status, your blood work, your goals and wishes, your symptoms, and your MRI images. And then, of course, there's stopping rules. And those stopping rules include, do you want to be on that therapy? Do you feel well enough and think it's worth it? Do you think it's safe? Do I think it's safe as your clinician? And it could be related to the tumor and its treatment, or it could be totally unrelated. It could be related to a general medical flare or a car accident. And then thirdly, is it getting the job done based on the pre-selected goal of why we started the treatment to begin with? So if one of those things are no longer relevant, then maybe it's time to stop that treatment chapter. And then, of course, are you interested in a clinical trial? Really, a trial is a good idea unproven. It is another option for patients and their families. It's not necessarily guaranteed to be a better treatment. For instance, when we look at the National Cancer Institute and the clinical trials that have been hosted in America and internationally, the overwhelming number of trials have been negative, which means patients either do just as well or less well than the standard arm. Now, my life is to be a clinical trialist. I literally wake up every day with my entire goal of providing patients options, including clinical trials. But there's a humbleness to knowing that they're not for sure a better option, and they're not right for every patient. So the goal is to be able to put the potential role of a trial into the balance of your overall care. So maybe it's not right for one chapter, maybe it becomes good for another chapter. And importantly, there's lots of different types of trials. There's trials that are therapeutic. Some are more supportive care, like does this medicine lower my fatigue? Does this medicine help me walk better? Does this medicine help my mood? Does this medicine lower my seizures? And then, of course, there's other types of trials that your clinicians may ask you to be part of that are ways of looking at outcomes amongst groups or risk factors amongst groups or testing your tissue and donating that to science. And there's very different levels of trials, and these are extremely important for you to know because they involve phases. One, is there any safety? Maybe it's first in brain or first in brain tumor or first in man. Or a phase 2 is, does it show any signs of working? And a phase 3, we know that this drug globally works, but how does it compare to existing therapies? And then, of course, how to search trials. There's many well-vetted search engines. I want to direct your attention to the ABTA Trial Connect, which is an outstanding resource. There's also clinicaltrials.gov, etc. Now I want to talk about strategizing for optimizing interactions with your healthcare team. I want to help you prepare for a new patient visit. Some of the things to do would be send in your new patient paperwork, bring in all of your doctor's names and faxes and phone numbers where you want things sent. Make sure you have medical record releases on hand from where you've been and where you want to go. Make sure that you bring CD-ROMs of your images and that you've absolutely made sure that they've either been sent ahead or that you bring them. Make sure that the clinician looks at them themselves, him or her. Make sure that the final path report is with your new doctor, not just that it's one type of tumor, but what about all those molecular genetics that are so important to treatment decision making. Make sure you bring your insurance cards, your prescription cards, the information about your pharmacy and specialty pharmacies, and ask about the possibility of talking ahead with a nurse navigator. Are there valets to help you park? Are there volunteers or transporters that can help you get around or optimize your visit? And then update your contact information often. It's very important that as your cell phone changes or you have new loved ones that you want to make the point person for your care or emails, make sure that those are updated in your medical record. Make sure you allow for blocked numbers. As many times when doctors try to call patients and family members, it's from blocked numbers through the hospital system. And make sure that your voicemail identifies yourself so that we know it's you, so that we will leave a message. If we can't tell it's you or your loved one, we're forbidden to leave a message. So please make sure that your contact information is in all those areas. And preparing for every visit. Have your questions ready or send them in beforehand. I want to direct you to an awesome resource through the ABTA called Questions to Ask Your Team. It's a great primer on things that you can do to make sure you've got all the questions ready to go for your healthcare team. Make sure that you are keeping up with what the time slot is for your visit so that you can prioritize what you most want to get across, and then make a date either through a portal or through a next visit of when are you going to have the remaining goals and questions addressed. Make sure you know what medicines you need refilled and keep your contact information updated. Review your imaging with your clinician. You can put photos on your cell phone so that wherever you are in space and time, you've got your own recent pictures on your cell phone. Make sure that you request CD-ROMs of your images and ask ahead before you get your MRI done. And make sure that you're making sure that each of your doctors that are important to see those images have a copy. And ensure your provider looks at your images, not just reads the report. It is only the clinician that can interpret that scan, not just the radiologist, in exclusion of your information. Ask about multidisciplinary tumor boards, especially if you're told worrisome news. Make sure there's a collective wisdom about your individual situation in all of your options. Use your electronic portals. I can't stress that enough. They're unbelievably helpful to lower the communication challenges between providers, clinicians, and caregivers. Use technology in telemedicine. Ask ahead. Can you use speakerphones, FaceTime, Skype? Can you tape the clinician? What about virtual tumor boards and virtual second opinions? Extraordinarily helpful ways to lower the bar of communication and maximize the information and outcome in your healthcare. Lastly, I want to talk about advocacy and empowerment tips to optimize the lives of everyone touched by brain tumors. Not just patients, but their caregivers, their neighbors, their family, and the community. So I want to encourage everyone to utilize patient-centered and caregiver-centered resources. So visit sites like the ABTA for social support resources and other online and community resources. Look in your community, state, nationally for support groups, blogs, chat rooms, social media outlets. Some of the many examples include fertility preservation, chemotherapy teaching, memory emotional well-being or relationship services, navigator programs, financial and social services, wellness centers, genetic counseling, cancer screening programs, and survivorship programs. Each of these can be tremendously impactful in living your longest and best life. Patient and caregiver assistance programs can be available through pharmaceutical companies, pharmacies. They can transcend between access to drugs, copay assistance, nurse navigators that can help you monitor the safety and tolerance of the drugs once you're on the drug. You can look up different state, national, and local social work, financial assistance, and through the help of nonprofit associations like the ABTA Stay Connect program. Ask about transportation around the hospital and around the clinic, and ask about other medical associations, civic or community or government resources that you and your loved one can tap into. Rate your experience. Those satisfaction surveys that you're sent matter. They can be things that have been sent by your provider or hospital, or they can be things that are like healthgrades.com or vitalsigns.com. They also can be social media outlets like Facebook and Twitter. Your clinician, your healthcare team, and your hospital use them for things that make a huge difference in your care. They may impact reimbursement for your hospitals and clinics, how much money Medicare and private insurances will reimburse hospitals and clinics for doing a good job and less money to those not doing a good job. It can be things like even quality bonuses for your providers, where it's pay for performance. The better the job the clinician does, they should be reimbursed or given the chance to get incentives such as more educational dollars to get more education, etc. These things are used for marketing and PR. What are the areas of unmet need that we can go out and be able to enhance services in deserved unmet need communities or to different tumor types or different groups. Very important. And lastly, they can be used at policy changing committees at the level of each doctor's clinic, the larger clinic group, the hospitals, or at the state and national level. So if we hear that there's a trend of an unmet need or a burden or a request or a dissatisfaction, we can channel our energy and our dollars to improve your life. So rate your experience. Vote and participate at the county, state, national level. Know the issues, know the dates and methods of how to vote. You can do email campaigns. You can be at in-person events and vote, vote, vote. It matters. I want to direct your attention to an advocacy site through the ABTA that is a wonderful way to get involved and make a forever positive impact on the care of you, your loved ones, and future generations. Lastly, donate your time, talent, and resources. So many of us come into each one of our healthcare challenges almost analogous to a thunderstorm, and it just seems like we can't see past just a little bit. But when we exhale and when the sky is clear, find ways that we can give back and pay it forward in our community. Sometimes it's by volunteering, and there's sites through the ABTA that can link you up with the best fit for you, either in your local community or beyond. Consider joining as a patient representative at a hospital or community board, and consider utilizing the things we have that don't always use to their fullest, like airline points, hotel points, gas cards, store cards, Molly-made coupons, and look for avenues to share them for other people in need. And so lastly, we've talked today about patient advocacy. How can patients, their caregivers, and those who love them live our best life? It's partly about medical pearls of wisdom that each specialist wants you to know, how to optimize each of our interactions amongst the healthcare team, and just advocacy and empowerment tips for everyone touched by brain tumors. With that, I want to thank each of you for participating and welcome any questions now or in the future. And you are welcome to contact me anytime if I can ever be an added value to any chapter in the novel that you or your loved one are writing. Thank you so much.
Dr. Dunbar will now take questions. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. The first question I have is, what steps should one take if they do not feel comfortable or agree with their doctor's suggested type of treatment?
That's an excellent question. One of the biggest reasons that can occur is because the clinician has not spent the time to explain what their rationale for that treatment may be. If that exchange has occurred and the patient and their family truly don't feel that that is in their best interest, I strongly encourage each patient and family to feel very empowered to get a second opinion. And clinicians fully understand that life is a team sport. And I encourage everyone with grace and full empowerment to approach the clinician and say, I would like to get a collective wisdom. I want to make sure that I've turned over all the stones so that I feel at peace in my head and my heart that I'm doing the right thing in this treatment chapter. And that clinician should jump at the chance to meet your need. Should they not, that's a warning system that they are not open-minded to making sure that it is the right decision for you as an individual. But overwhelmingly, as soon as you let that clinician know that you would like to broaden the opinions, to get a collective wisdom, it almost always is a benefit for not only the patient, but for the clinician. So I encourage you to do it.
Thank you, Dr. Dunbar. That segued into our next question that asks, what are some signs that a patient should get a second opinion?
Well, definitely if the patient or their loved one feels that that clinician doesn't have a large volume of experience in specifically the type of tumor that they or their loved ones are being treated for. And there's no fault or shame in that. There are different practice environments, and there are different experience levels that different people have. And so that's one would be, asking how many of these do you treat? How comfortable do you feel? Are there people that do just this or similar things and are dedicated to this type of tumor and these types of treatments? Another would be if there's just not a good hand-in-glove fit between sort of the patient and the clinician. If it just doesn't feel like really a trust bond and a knowledge bond, then that can sometimes be an indication that maybe a second opinion would be beneficial. I would also say a third very important reason is if you were told worrisome news and you're thinking that you may need to go to a new treatment chapter, that is a time for equipoise. That is a time to say, wait a second, unless I'm being told that the situation is extraordinarily urgent, then let me take some time to collect my thoughts as a patient or loved one and to be able to explore what other things might be out there and to make sure I'm getting a collective wisdom myself. Because maybe there are 3 or 4 options that are excellent options immediately available to you, but 2 or 3 ones just a step or 2 away, and ultimately they may be what you want to do. So definitely experience and kind of sophistication of your treatment team. 2, if you're ever told any kind of worrisome news. And 3, whenever you're told that a new treatment may be needed, the time to collect your thought and make sure that you have as many options available to you.
Thank you. Our next question asks, how does one self-advocate when they are faced with the overwhelming feeling of having too many people offering their opinion or advice? Or as phrased, too many cooks in the kitchen?
That's an excellent question. So what I often will share with my patients and their families is that there are so many well-wishers and do-gooders that authentically really think they're being helpful. That can do a few things. One, it can put the patient or the family into like PTSD, where they have to continually update or justify or defend what they're doing. They're updating everyone else. They're fatiguing themselves with living through or sharing all this information all the time. So quiet all that madness. Get into a team of healthcare workers and maybe a smaller set of friends or family that you trust, that you can then say, okay, this is my A team. And to everyone else say, thank you very much for your well wishes and your prayers. If you would like an update on what's going on in my life, you could go to my Facebook page, my caringbridge.com page, and get updates and find out ways you can help me. But I will not be individually corresponding to each message I get. And so I tell a lot of my families to put like an out-of-office message or an automatic reply on their voicemails, their emails, their cell phones, their home voicemails, and really try to say, I will not be returning individual correspondence. This is how you can find out what's going on with me and how you might be able to help me and my family. And keep that sort of A team tight of people you really trust that you can utilize to help make sure that you're making the right decisions. Because you're absolutely right. Too many cooks in the kitchen is similar to analysis paralysis. You barely can move forward, and it is tremendously fatiguing, scary, and unsatisfying.
Thank you. Our next question asks, regarding the treatment team, what is the difference between a neuro-oncologist or a medical oncologist, and is one preferred over the other?
That is a wonderful question. So a neuro-oncologist has done a fellowship program in diseases that affect the brain and spine, whether primary metastatic, as well as the symptoms and other nuances that come along with the treatment of patients affected in those organ structures. A neuro-oncologist can come from the backbone education of neurology or the backbone education of medical oncology, and then they meet in the middle for that higher level training. So there are fellowship programs around the country that will allow either or both into their training program, depending on how that training program is structured. Everyone comes out of that training program equally qualified. I do also want to share that radiation oncologists and neurosurgical oncologists also in their profession have the opportunity to have done dedicated subfellowships or have been able to get extreme experience in the care of brain and spine tumor patients. So the goal, though, is even if you are able to get your care routinely in your community and it is not a dedicated brain or spine tumor specialist, consider periodically being able to interface with a brain and spine dedicated specialist at least every few months or periodically, or when a treatment decision is being made. So in general, I am a huge advocate of getting as much care as you can, as close to your home community as you can. And that is right for everyone in so many different ways. However, being able to periodically check in with experts really is, I think, the perfect balance of helping not only the patient, but their caregivers get the best possible care.
Thank you. Your answer has segued into our next question that reads, what do you do if your neuro-oncologist perspective is limited to just treating the tumor, but not the person as a whole?
That is a very common scenario where the neuro-oncologist is very, very focused on a narrow set of care goals. And sometimes that is the piece of the puzzle that they can provide to you. However, all of the rest of you matters. And so what I would approach is either through them or through another specialist in your life, another provider in your life, identify and articulate the other things that you would like carried out, because other clinicians can serve various roles. So, for instance, there might be a neuro-oncologist trained in neurology that feels very comfortable also taking care of memory issues and seizures, but potentially the medical oncologist may not feel as comfortable taking care of your seizures or your memory troubles. However, they could refer you to a neurologist or make sure you can see one on the same day, et cetera, or at least be able to talk to one on the phone. Sometimes clinicians see patients more innately from a 360-degree perspective, and some really kind of take a more narrow view of how they care for a patient. But the most important thing is that you get all the care that you need. So sometimes that means that different clinicians sort of take different parts of your care forward. So you in your area may utilize a palliative care specialist that is an expert in symptom-directed care. Or you may have an ophthalmologist, or you may have a counselor or a memory specialist. So it's really about identifying and articulating what are your needs, what are the things you would like in your life, and then working with the providers you have to make sure that all of your needs are met.
Thank you. Our next question asks, do you think there is an advantage to getting radiation from a facility that treats many brain tumor patients rather than one that is closer to home that treats fewer?
That's a wonderful question, and I will tell you it is very specific to the individual person's tumor. So this is a great example of what you would consider a one-time radiation second opinion. Let's say you are contemplating getting a particular type of tumor radiated and you live in the community and you're not sure if that's where you need to get it done. If you ask your clinician, can you go to what is the closest place where there would be subspecialty care, whether at an academic center or a high-volume brain tumor center like mine, et cetera, and say to that radiation oncologist, what would your recommendation for radiation be? What would your treatment protocol be? What would your schema be? And can you tell me if you feel that that recommendation could be done in my community? And if so, would you be willing to share your protocol and your recommendation with my local radiation oncologist and be available to them as needed. And it's a win-win for both of those radiation oncologists. And that way, maybe at the end of your treatment or at the time the radiation is being evaluated with post-radiation treatment scans, you may elect to go back to that radiation oncologist at that subspecialty center for an evaluation of the monitoring. However, if that clinician says, you know what, I really do want you to get care for your brain tumor with radiation at a subspecialty center or a high-volume brain tumor center because, and they can articulate why, their equipment might have less of a toxicity, their protocol may have potentially more efficacy, your ability to get treatment there would provide you with a clinical trial, or your ability to get treatment there would give you an entire portfolio of other services that you could do at the same time that would benefit your tumor treatment fight, like there's support groups, nutrition, dietary, therapy, other specialists that you could utilize during the time you're getting your radiation there. Hear it from them so that they can tell you where is the best place to get radiation. And very similar analogies would be for where you get your chemotherapy, whether or not it's a trial or a routine treatment, or where you get your surgery. It's about often getting a second opinion and asking each of those different providers in that sacred physician-patient relationship and saying, why here or why there, and what would you do if you were a member of my family? And really make them articulate what their best recommendation is to you.
Thank you. We have time for just 2 more questions. The first question asks, what questions should patients ask their treatment team when faced with a reoccurrence, signaling that maybe the first treatment type may not have been fully effective?
This is a very common dilemma since almost all tumors that affect the brain and spine are technically things we don't think of as one-and-done treatment. They may or may not be listed as things that are curative or palliative intent, all those fancy terms, but ultimately we are in a lifetime continuum with our patients, and almost every one of our patients are faced with a potential or real recurrence or progression. And questions to ask at that time would be, what are my options? What are the best tools at this time to help me optimize my treatment fight? The PowerPoint that I had that had the starting rules, when and what to start with treatment, that had the green go sign, that's an excellent example of some of the questions. What's the general science? What's the general safety with a variety of options? What are my goals and wishes? What about the logistics? What about the cost to me? What about the order or the politics of therapy? Those are all very important questions. And then you want to get a sense of, what does this mean for me and my outlook? What is this going to change my likely future health and well-being, the length of time that I may or may not be alive? Those are important questions to ask. And then another very important question to ask is this really a recurrence or progression? Could this be treatment effect or pseudo-progression? And that's often when multidisciplinary tumor boards, virtual tumor boards, or second opinions can be priceless, because there's many times that the first information that you get may not be the ultimate final collective wisdom.
Thank you. Our last question asks, is it equally important for patients to share how well they are doing in comparison to the possible challenges they are facing?
That is a very important point. We know that all patients of all tumor types in all states of health and wellness, a more positive attitude, eating for health, drinking and staying hydrated, daily activity and exercise, lowering your stress, improving your emotional well-being, improving your motivation and your sense of self. All of those are strongly correlated to an improved outcome. And it's important that patients and loved ones are able to share and express their joys and their improvements just as much as it is to report a symptom, a wonder, or a worry. And those are not only important to your healthcare team's job rewards and joy. We want to celebrate them with you. They improve our sense of well-being. But also, we want to track the positive symptoms and outcomes, just as we want to know if there's a new trouble brewing, etc. And I think it's important for patients to share their stories living with their tumor. Because a lot of times, if you go on the general internet, it's full of a lot of things that sound very scary and worrisome and hopeless. But if we share positive improvements in our quality of life, in our symptoms, and in our tumor fight, that bolsters all of our commitment to living our longest, best life and creates an environment in which patients and their clinicians have the optimal opportunity to work together.
Thank you. That is all the time we have for today. Thank you all for joining us, and thanks once again to Dr. Dunbar for her wonderful, informative webinar presentation. To help connect patients and caregivers with information and resources that can help support them in the brain tumor journey, call the ABT Care Line, which is staffed by caring professionals, at 1-800-886-2282. That is again 1-800-886-2282. Let's pause for just a moment to conclude our webinar recording.